Infective endocarditis. So first of all, we're gonna discuss what's the presentation gonna be like. So history of the patient is gonna basically whenever you read infective endocarditis, there are a lot of symptoms and a lot of lesions to take care about, and it can become a little bit overwhelming. But when the patient presents, it's like really weird because the presentation is quite simple. So I'll give you guys an example here, like history of chronic fatigue, weight loss, and fevers. That's it. So you might ask, this looks like TB. Yes, it does. And you need to make sure that you don't fall for that trap. And the other two things that you might confuse infective endocarditis with are post-streptococcal glomerulonephritis, because there is blood in urine, and in infective endocarditis the patient can also have blood in the urine. And the other condition is that of rheumatic heart disease, because in that the patient also has a murmur, plus there are subcutaneous nodules which you can confuse with the skin findings of infective endocarditis. So the two important differentials that you need to keep in mind when solving a question or seeing a case is that of PSGN and rheumatic heart disease. That's the two important ones. So it's gonna be history of chronic fatigue, weight loss, and fevers. That's it. Rest of the time must be made with either physical examination, blood in the urine, or history of prosthetic valves, IV drug use. So there are a lot of factors that account into it. It's not just plain chronic fatigue, weight loss, and fevers. You need to know the history in order to make a tie of this diagnosis. So another question, what if you suspect infective endocarditis? What are you going to do next? What is the next best step if you are suspecting infective endocarditis based on the symptoms? You're going to go for an echocardiogram, that too specifically transesophageal echocardiogram, in order to visualize the vegetations on the valves. This, and the other thing you're going to do is order a blood culture, because infective endocarditis, because it results from bacteremia, so you might be able to culture the organism as well. But the first next step would be transesophageal echocardiography. If the transesophageal echocardiography is not listed in the options, you use the transthoracic echocardiography. But the more high yield and the more specific one is the esophageal echocardiography, because it visualizes the vegetations better, because obviously it's going through the esophagus, it's not from the thorax, so that's why the visualization is better. They may also say that the patient was diagnosed with a congenital murmur when he was born, signaling that he is more prone to developing infective endocarditis. Pre-damaged valves are more prone to developing infective endocarditis. Bicuspid aortic valve would result in damaging of the valve, and that would make it more prone to infective endocarditis. Patients with mitral valve prolapse are more prone to infective endocarditis. So pre-damaged valves, that is one thing that you need to keep in mind as well. Don't fall for TB. Keep an eye for other times in the history. Yeah, it's because the presentation is a little bit. So they are gonna give you chronic fatigue, weight loss, and fevers, and they might tell you that the patient says that he had a history of murmur when he was born. He had a congenital murmur. So that is gonna help you make a tie-in. And then they might also mention that there was no murmur at first, but after the patient presentation, you auscultated the heart and you found a murmur. So new onset murmur is also indicative of infective endocarditis, especially with this presentation, chronic fatigue, weight loss, and fever. And if you can find another thing as well, like for example, the high yield skin findings, blood in the urine, that's gonna make it even more easier for you to make the diagnosis. So let's give it a read from the table. Infective endocarditis, congenital heart disease or prosthetic valve. Yeah, that makes the person more prone. Previous endocarditis, obviously, yeah, if he had endocarditis once, can have it again. Intravascular catheters, because they cause transient bacteremia, but they're not that much high yield. The first two, prosthetic valves, congenital heart defects of the valves, previous endocarditis. You just need to keep these three in mind, because these are the most high yield ones. So how what are gonna be the physical findings? The highest yield one, new murmur. That is what is gonna help you make the most tie to this diagnosis. Chronic fatigue, weight loss, and fevers, plus the patient presents with a new murmur. should already know where this is going. So these are the helpers, what I call them, because these findings make it easier for you to confirm that this actually is the diagnosis, and these findings make it easier for you to be confident about your diagnosis. Skin findings: if there's a painless erythematous macules on the palms and soles, that is called Janeway lesions. I'm also going to show you both of them. These are painless. Ocular nodes are painful and they are nodules. So here we go. These are macules, red macules on the palms and soles of the feet. So why are these caused? All of these findings are because of the obstruction of microcapillaries by the vegetations, microvegetations that are launched off. So these are occur secondary to microabscesses in the capillaries in patients with IE. So these are macules. One more thing I would also like to point out to you guys is the difference between macules, nodules, pustules, and macules, nodules, pustules, and papules. So I also wrote all of these specifically here just to make sure, because most of the people don't know the accurate distinction between all these three. So we'll also gonna discuss that. Macule. What is a macule? Macule, when it comes to the skin, it's a flat lesion. So you're just gonna visualize the blood, and the lesion is gonna be at the level of the skin surface. Like for example, I'm gonna draw you. This is the skin, and if macule is, this is the level of the macule. So it's not raised, it is not forming a plateau, that's it. It's just at the level of the skin. Erythematous means red. Erythematous macule, red macule, and macule is at the surface of the skin, just at the same level. So when it comes to papule, what is a papule? Papule is slightly raised like a plateau. That is what a papule is. Like I am drawing here. So that is the skin surface. The arrows are pointing towards that is the skin surface, and you can see the one I am just circling. This is a macule. It's slightly raised when it comes to the skin surface. It's not markedly raised like this. It's just slightly raised. It's forming a plateau just like that. It's just slightly raised. That is called a papule. So there's a common terminology, maculopapular rash. What do you mean by that? Because it's a combination of both macules and papules. Macules, when it comes to Urdu, we call it tappad pad gaye, tappad. So this is what a papule is basically. So maculopapular lesions are going to be at the surface of the skin at the same level, and as well as a slightly raised lesions as well. So combination is termed as maculopapular rash, a combination of macules and papules. So that is how it presents. Now we'll also discuss what is a nodule and what is a pustule. So a nodule is basically, this is the level of the skin. If this is the level of the skin, a nodule is a markedly raised lesion. This is a nodule. And what is a pustule? Pustule is basically a nodule is markedly raised and it has a rubbery consistency to it. And what is a pustule? Pustule also looks like a nodule, but it is filled with pus. So in order to give you an example of what a pustule looks like, when you might have seen cystic acne breakouts on your face, there is a like a dome shaped lesion with a pus inside it. That's termed as pustule. So a dome shaped lesion with pus inside, pustule. A markedly raised rubbery consistency lesion is termed as a nodule. Papule is a plateau just slightly above the skin surface, and macule is at the level of the skin surface. So these are a few core concepts when it comes to dermatology and identifying the lesions. So I wanted to point them out as well. So the Janeway lesions are gonna be painless and they are gonna be macule like red. But when it comes to ocular nodes, they are gonna be nodular and they are going to be painful, and they're going to be present at the toes and the fingers. They are present at the periphery. That is what I mean to say. Painful ocular nodes going to be painful, and the Janeway lesions are not going to be painful. Palms and soles, Janeway lesions. At the fingertips or the toes, ocular nodes, that would be painful. Both ocular nodes are usually red and violaceous. Violaceous means a little bit purple as well. So these are the two high yield ones, and the other ones are rot spots and splinter hemorrhages. Splinter hemorrhages are also really important. When the vegetations are launched off in the systemic circulation, they come into the capillaries under the nail bed and they cause hemorrhages. So when you visualize the patient's nail, you can see like small hemorrhages here. So they will show you a picture of that as well. I'll show you the picture of Janeway lesion and osseous nodes, but you most probably will see a picture of the splinter hemorrhages if you're doing U-World or anything else. So I'm gonna show you guys. This is osseous nodes. It's nodular, it's at the fingertips, it's painful, and it's red. These are Janeway lesions. They are non-painful, non-tender, and the palms and soles, and they are also red and they are macular, so no, they are not raised. So these are rot spots. How do you identify rot spots in the retina? The center would be clear, surrounded by hemorrhagic periphery. This is just a plain simple hemorrhage. This is a rot spot. What is the difference between a hemorrhage and a rot spot? Rot spot is going to have a central clearing and a surround hemorrhage around it. That is what a rot spot is. It is formed, it occurs when the vegetations are launched off into the retinal capillaries and they cause a hemorrhage. So we've covered all the high yield ones. So I wanted to talk about PSGN and rheumatic heart disease. They're going to give you a case of rheumatic heart disease. The patient is going to have a new onset murmur, and the patient may also have a history of impetigo. As you know, it's a streptococcal infection that leads to the autoantibodies against the heart antigens, and that results in destruction of the heart valves. And it can occur after either a sore throat or impetigo. So usually the question is, they'll give you a history of a patient with a crusty lesion. They might not even mention honey crusted, they might just say yellowish lesion. So you're gonna assume it's a lesion, and the patient is gonna have fever, the patient is gonna be having a weight loss, and they're gonna give you that the patient now has a new onset murmur as well. You're gonna think it's infective endocarditis. No, it's not infective endocarditis. It's rheumatic heart disease, and the lesion that they explained was not a Janeway lesion, not an osteolar node. It was impetigo. So that is the first confusion, and the second confusion is usually caused by the post-streptococcal glomerulonephritis, because when it comes to infective endocarditis, one of the systemic manifestations are hematuria, glomerulonephritis. So red urine, blood in urine. So they might say that the patient has blood in his urine, and the patient now has subcutaneous nodules. So you might think in PSGN there is no murmur, but the red urine and the subcutaneous or skin finding may confuse you with the fact that it might be infective endocarditis, because they're just going to say the patient has subcutaneous nodules, and you might think those nodules are actually might be osteolar nodes, and blood in urine, yeah, sounds like glomerulonephritis due to infective endocarditis, but that's not the case. So they might also give you a history of the patient having mitral valve prolapse, and you might even think it more that I think it's infective endocarditis. But when you see the picture of the skin lesion, it's gonna be just simple subcutaneous nodules. They are not gonna be osteolar or Janeway nodes. So these are the two. I just wanted to point out these two important ones. So diagnostic testing, I told you, echocardiogram is going to show the vegetations. That's the high yield one. And the second one, you do a blood culture, and if the culture grows an organism, that is also indicative. So what is the treatment for acute? Empiric anti-treatment with Vanco, and subacute treatment based on culture results. So now we'll also give a read here. About 75% of the infective endocarditis have previously damaged heart valves. Yeah, that is previously damaged heart valves are more prone, with mitral valvular disease being the most common one. Patients with mitral valve prolapse have 5 to 8 times higher risk of IE. Yeah. So macules non-raised, papules slightly raised, plateaued relative to the skin, nodule markedly raised from the skin, round, protruded, pustule, pus filled. So yeah. So vascular and immunologic manifestations of infective endocarditis. Vascular phenomena, or if the vegetations are launched off, they can cause infarcts in the pulmonary vasculature, infarcts in the cerebral vasculature, splenic infarcts, Janeway lesions, immunogenic. Osler nodes, I told you what they are, rot spots, it's the same. Everything, the above table covered almost everything that you need to know, especially with the discussions regarding the DD, you're more than good to go. So, what is the criteria for diagnosing? The two major ones I told you. Obviously, it's going to make sense. The vegetations, presence of vegetations, that's a no-brainer. And the second one is you visualize when you do a blood culture, you grow organisms. So it represents bacteremia, which is the number one cause behind infective endocarditis. So you have both of them. So you just need one of these two. And other than that, if you get two minors, you're good to go for infective endocarditis. They're gonna give you a combination of definitive, i.e., possible, i.e., I just need you to keep the simple one in mind. The major ones, obviously, the two no-brainer ones. The first one is gonna be you visualize the vegetations. The second one, organism in the culture, blood culture. You get one of them plus the minor ones. What are the minor ones? Ask yourself. It's going to be simple. The systemic findings like blood, like the skin findings, osteal nodes, or maybe Janeway lesions, splinter hemorrhages, or it can be blood in the urine due to glomerulonephritis, just like these. So let's give it a read. Predisposing cardiac lesion is also a minor criteria. IV drug use, that's embolic phenomena. That is the one where you get cerebral infarcts, splenic infarcts, anything like that. Immunologic phenomena like glomerulonephritis, positive blood culture. So you just need to keep the major ones in mind, and the minor ones are automatically gonna make sense to you. Like the skin findings, blood in urine, if the vegetations get launched off and they cause infarct at any region, like in the cerebral arteries, in the splenic arteries, anything like that. So yeah, it's gonna make sense. Or another one was as well, if the vegetations lead to extension and cause local infection or distant infection. Local infection can be perivalvular abscess, or the distant one can be splenic abscess. So yeah, that also makes sense. It's a minor criteria as well. The major ones, you just need to keep the major ones in mind, and you just tie in two or three minor ones and you're good to go. That's it. And what happens if you're suspecting it? You go for a trans, thoracic, or esophageal. Trans-esophageal echocardiography, that's what you go for. As I told you, clinic findings, fever, that's the biggest one, and a new onset heart murmur. These are the two main ones. Other than that, it's just you might find them, you might not find them, you might find one of them. It's variable, but the fever and heart murmur, these two are fixed. So you need to hammer this in your mind, what the patient presentation is going to be like. Petechiae, heart murmur, splinter hemorrhage, osteal node, Janeway lesion, neurologic phenomena like cerebral infarcts, splenomegaly, rot spots, retinal. Okay, we're done. So these I showed you guys these pictures. Common complications of infective endocarditis. You don't need to read the table first, just listen to me. What can be the common complications if the vegetations extend? The vegetations are basically due to bacterial adherence to the fibrin clots, and that can result in local infection or distant infection. Local infection would be perivalvular abscess in the valvular region, perivalvular just adjacent to the valves. It can go to the distant area. For example, it can extend to the spleen and cause splenic abscess. What else? It can cause splenic infarcts as well. It can cause cerebral infarcts as well. It can cause glomerulonephritis as well. And everything. We've covered everything. Now let's just give it a read. Local heart failure. Why would heart failure occur? Because of valvular incompetence long term. That is gonna cause heart failure, not instant heart failure. Perivalvular abscess around the valve because it's bacterial in nature. Pericarditis, I don't give a shit about pericarditis that much. It's not high yield. Intracardiac fistula, yeah, that's also an important one. The fibrin clots in the vegetations might cause degradation of the intracardiac walls leading to fistula formation. distant septic emboli in the spleen causing splenic abscess, metastatic abscess, splenic abscess, organ infarction, splenic infarct, renal infarct, cerebral infarct. It's easy to make sense about everything. So, how are you gonna diagnose perivalvular abscess? It's a high yield question. So, if a person, it's really obvious that a person is suffering from infective endocarditis, and you do an ECG of that person, and in that ECG you visualize a heart block. What is the reason behind that? Simple as that. It's perivalvular abscess. New onset heart block in a patient suffering from infective endocarditis. It's gonna be perivalvular abscess because perivalvular abscess results in heart block or uh, cardiac conduction defects like heart block. So let's give it a read as well. Perivalvular abscess occurs in 30 to 40% of patients with aortic valve infective endocarditis and most common in those with bicuspid valve. So infective endocarditis can involve aortic valve or it can involve mitral valve. For example, if it involves aortic valve and causes aortic regurg, the constant regurg chronically can cause heart failure. That's why they've written heart failure here. So it is generally suspected when patients with IE have persistent bacteremia or develop cardiac conduction abnormalities. That's how you tie in the perivalvular abscess. So if a patient of infective endocarditis is being given antibiotics and the fever is not settling down and you do culture the blood and the organism is still being cultured again and again despite high dose antibiotics, what's the reason? An abscess has been formed. Second, if a person with known history of infective endocarditis or very likely symptomatic infective endocarditis that you have not confirmed yet, even then so, and you can make a tie without even confirming the diagnosis. All the symptoms point towards IE, then the patient suddenly develops arrhythmia sort of thing. You do an ECG and the ECG is shown there and you see that there's a heart block in the ECG, like consistent, like progressive prolongation of the PR interval with the dropped QRS or irregular unsynchronized QRS complexes and P complexes resulting in which represents complete heart block. The P waves are randomly occurring and the QRS are occurring at their own pace and the P waves are occurring at their own pace. So you see there's no connection between the P and the QRS. So that's a complete heart block. So you go for perivalvular abscess as the reason behind this. Aortic regurgitation due to valve disease usually causes an early diastolic murmur best heard. So what is the difference between aortic regurg due to aortic valve incompetence or aortic root dilation or aortic root disease? So aortic root is basically above and the aortic valve is a little bit lower. So if there's aortic regurg you're at due to the valve, you're gonna hear it at I'm gonna draw the APTM here. So we have A here. So just give me a second. So we have A here. That is the aortic area at the second right intercostal space. We have sternum here. We have P here. Second left intercostal space. APT and M. So that's how you memorize it. APTM. It's gonna be really easy that way. APTM and this region that represents the intermediate region where you get a little bit of everything. I'll explain what I mean by that. So if the aortic regurg is due to aortic root disease, it's gonna be a little bit above. And where is it gonna be? It's gonna be here at the A region. But if it's because of the aortic valve, it's gonna be here between P and T. So P and T is at the fourth left intercostal space and the region between it can be third or the fourth one. So you can assume it's the third left intercostal space. What do you hear? Here you can hear the aortic regurg due to aortic valve disease here. You can also hear other you can just give me a second. You can also hear other like A and P. The way I remember it is A P regurg. So this line represents A and P regurg due to valve. And if the regurg is due to aortic root disease, it's gonna be at the A area, which represents aortic stenosis. You're gonna hear aortic stenosis here, you're gonna hear pulmonic stenosis here, you're gonna hear A and P regurg here, you're gonna see everything related to tricuspid here and everything related to mitral here. And where are so let's just revise it again. A, P, A and P regurg, T, M. A, aortic stenosis, aortic regurg due to aortic root disease. P, pulmonic stenosis, and what is gonna be other than that? The P and T are also gonna include ASD, atrial septal defect. So the reason behind you hearing ASD here is because ASD results in greater blood volume in the right atrium, so there's a greater flow across the tricuspid valve, so you can hear a ASD, atrial septal defect here. And because there's a greater amount of blood volume in the right atrium, so the flow across the pulmonic valve is also greater in ASD, so the ASD is also heard here. You also hear pulmonic flow murmur here as well. So you hear pulmonic stenosis, pulmonic flow murmur, ASD here, and you hear tricuspid everything, regurg and tricuspid stenosis and ASD here. In addition to that, you hear a VSD here as well. So again, aortic stenosis, aortic regurg due to aortic root disease, pulmonic stenosis, A and P regurg here, and tricuspid, everything, and P and T are going to include ASD and T is going to include VSD. So you just have to memorize this a little bit. So the reason behind this discussion was to let you know that the aortic regurg can happen at the aortic area as well as between P and T. That was the reason behind this discussion. Depending on the reason behind it, if it's just the valve, it's you're gonna hear it between P and T. If it's the aortic root, you're gonna hear it at A. So A basically represents the stenosis. A and P represent the stenosis of the valves. The regurg is gonna be heard here. So I just wanted to point out that as well. So just like everything else, perivalvular abscess or infective endocarditis, if it's suspected, you do a transesophageal echocardiography to visualize the abscess and vegetation. So transesophageal echocardiography is likely the best step in this case because it is more sensitive. They might have presented a case where you diagnosed perivalvular abscess and they did not tell you that it's perivalvular abscess. They just gave you a case and asked what is the next best step. Should know it's perivalvular abscess, and in order to localize where the abscess is, you need to do a transesophageal echocardiography again. Even if you have already made a diagnosis of infective endocarditis, you need to visualize the abscess now. So clinical features of splenic abscess. Let's just ask yourself, where is the spleen located? Spleen is located at the left upper quadrant. So if you get a splenic abscess, you're gonna have tenderness in the left upper quadrant. Because it's an abscess, you're gonna have fever and it's gonna be high grade, and that's it. Right upper quadrant pain, tenderness plus fever, that and a reason behind you thinking that's a splenic abscess. That three things are the only things required to make a diagnosis. Infection, infective endocarditis, as I told you, you thinking that there's a reason behind the splenic abscess, like it might be a distant extension of the infection, like that happens in infective endocarditis. So that is a reason to suspect splenic abscess. And plus right left upper quadrant pain, tenderness and fever. That is classic triad: fever, leukocytosis, left upper quadrant pain. Why is there going to be a leukocytosis? Because it's an abscess, infection is going on and the body is increasing the leukocytes. So yeah, you're going to see leukocytosis on the CBC. The patient is going to have fever obviously, but the main high yield thing, left upper quadrant pain, left upper quadrant abdominal pain, that is the location of the spleen. So let's ask you a question. They're gonna say the patient presented with left upper quadrant pain and fever. That's it. And they're gonna say that the patient had a history of congenital murmur, and a month ago the patient had blood in the urine and a new onset murmur as well, which was diagnosed in the outpatient department. So I'm just giving you a made up scenario here, but it's gonna make sense to you that if you tie everything together, you know that the patient had a congenital murmur, so he's prone to infective IE, and a month ago he presented to the outpatient department with blood in the urine and a new onset murmur as well. And now the patient has left upper quadrant abdominal pain and fever. So what is the reason? It's simple. He had IE and the infection has now spread to the spleen, causing a splenic abscess. So the question is, what happens when a splenic abscess happens? What is the treatment for splenic abscess? So splenic abscess, spleen is like a really septated organ. You cannot clear the abscess completely. So the best way to deal with the abscess is to remove the spleen once and for all. Because if you give antibiotics, there's a high chance that the abscess is not going to resolve. So the treatment is splenectomy plus IV antibiotics. So you're going to use both of them. So if they ask you a question and a scenario like the one I just presented to you, so and ask you what is the next best step, the next best step is give high dose antibiotics and do a splenectomy. That is the only way you're going to get rid of it. So one more thing, left sided pleuritic chest pain. Splenic abscess can also irritate the above lying diaphragm and the pleura. That would then the inflammation and the irritation would result in a slight pleural effusion on the left side of the chest. Don't have to confuse it with lobar pneumonia or anything like that, because you might think the patient is having pleuritic chest pain, and if you see X-ray, you're gonna see blunting of the left costovertebral angle, costophrenic angle at the left side, and you're gonna see that it's an effusion. So don't confuse it with that. Effusion can occur because of the irritation and extension of the inflammation. So organisms most common implicated are staph and strep. Staphylococcus causes infective endocarditis. Strep also causes it. So yeah, usually diagnosed with abdominal CT. So this is also a really high yield point. How is splenic abscess diagnosed? Abdominal CT, not ultrasound, not X-ray, abdominal CT. So I want you guys to hammer that in mind. And the reason behind we use CT to do and visualize these organs is because the solid organs cannot be that much well visualized when it comes to X-ray. They don't show a lot of detail, and the ultrasound is also a really poor modality. So for example, if there's a infarct in the kidneys, the best way to visualize it is abdominal CT. If there's a lesion on the liver, the best way to visualize that is abdominal CT. If there is infarct of the spleen, in fact the wedge shaped infarct, it can be really well visualized if you use an abdominal CT. If there's an infarct in the, if there's an abscess in the if there's like what it's a pyelonephritis of the kidneys, it is really well visualized by abdominal CT. If there's an abscess in the kidneys, it is also really well visualized. If there's a tumor in the kidneys, it is also really well visualized using CT. If there is a infarct due to cerebral hyperperfusion or blockage of the cerebral arteries as a result of an emboli, that is also really well visualized when it comes to CT. So these solid organs, abscesses and infarcts in the solid organs, that is the summary of this discussion, are really well visualized when it comes to abdominal CT. So yeah, if when it comes to solid organ, infarct or abscess, go for abdominal CT. So combination of broad spectrum antibiotics and splenectomy, that's the treatment. Percutaneous drainage, that's not going to work. You have to do a splenectomy. So let's give it a read as well. Patients with pre-existing structural cardiac conditions are at increased risk of endocarditis. I've told you multiple times. There should be strong suspicion. That's how you go for it. In this patient who has mitral valve prolapse, 5 times more prone to developing associated 5-fold more risk, fever with systemic manifestations. Yeah. So this is the perfect presentation of a patient. Pre-existing structural cardiac conditions, mitral valve prolapse, fever, systemic manifestations like malaise, weight loss, and splenic abscess. That's all they gave you guys. And you have to go for infective endocarditis as the reason. They can also give you IE, then ask you for diagnosing splenic abscess, or they can just give you the scenario of left upper quadrant pain, everything like that, and say it's a splenic abscess, and the patient had fever, systemic manifestations like malaise, weight loss for the past 1 month, and the patient has a history of mitral valve prolapse. Then you tie everything together. You mitral valve prolapse, already prone, then developed infective endocarditis. That's why he's having fever and systemic manifestation. And now the infection just spread to the spleen, causing splenic abscess. So you have to. That's how you play the game here. Antibiotic alone for treating splenic abscess have a high mortality, up to 50% in some studies. No, antibiotics won't be able to clear it. So you have to do splenectomy as well. Surgical indications of infective endocarditis, that is also really easy to decipher even without reading. So how, what are the surgical indications? You give antibiotics and it's not resolving because it's a multi-drug resistant organism. No other option. The vegetations are really large and they're causing systemic obstruction, like the patient just had a stroke due to the vegetations going into the brain. The patient had a splenic infarct. The patient had a renal infarct. That extension of the infection, it might be just around the valve, perivalvular abscess, or it might go to the spleen itself and cause splenic abscess. So yeah, extension of the infection. I guess that's it. Let's give it a read as well. Oh, they've included acute heart failure as well due to valve incompetence. Yeah, if the IE is causing any sort of trouble other than just being IE, then you make a surgical intervention. Simple as that. If the IE is just IE and the patient is fine, then it's okay. We try to eradicate it. If we try to eradicate it, we're not able to do it because the organism is really like really an asshole. So what do we do? Surgical intervention. If the patient is had just IE, now the IE is causing trouble, like it's causing heart to fail due to valvular incompetence, you have to go for the surgery as well. If the patient is developing infection in the heart around the region like splenic abscess, you go for surgical intervention. It's not just the IE anymore, it's causing a lot of trouble. If it's causing infarcts, you go for surgical intervention. So IE can have local valve like perivalvular, septic emboli complication. Patients can deteriorate rapid. Urgent surgical intervention is indicated in those with any of the following: heart failure, localized or resistant extension like they form an abscess like splenic abscess or perivalvular abscess, difficult to eradicate pathogens. Okay, very high risk of embolism because of large vegetation, or persistent embolization of the infected, like the patient is developing repeated splinter hemorrhage, rod spots. If it's causing trouble, simple. If it's causing trouble, that is the biggest thing I would like to point out here. You guys can give it a read and hammer it a little bit more, but the discussion is more than enough that we had how to decide whether we'll go for a surgical intervention or not. Infective endocarditis with IV drug use. So what happens with IV drug use? The organisms are gonna be introduced to the right side of the heart first, because they're not gonna be, the drug users you inject in the veins, they don't inject in the arteries. So the veins are gonna lead to the right side of the heart, and the right side of the heart is gonna get damaged by the injected particles. uh, and then they move to the lungs filter out all the particles, and then they are not able to make it to the left side of the heart. So the IV drug users are going to have the right side affected, the tricuspid valve. So micro damage of the valves due to the particles hitting them, and the particles are introduced via the veins, results in bacteria becoming more easily being able to adhere to the damage. Simple. What happens with IV drug use? The heart valve on the right side gets damaged. The bacteria then attach and cause infective endocarditis. Tricuspid, most commonly infected. Staph aureus is the most common organism. Why? Because when they are injecting, the skin is punctured, the Staph aureus also enters, and then it adheres to the damaged valve. Septic pulmonary emboli, because it's not on the left side of the heart. Those septic or the embolic phenomena would be observed in the lungs. And how? The patient is gonna cough up, the patient is gonna have pleuritic chest pain, the patient can cough, can have a complaint of coughing, the patient can have complaint of blood tinged sputum as well. because of the hemorrhage resulting from the vegetations blocking the arteries and the blocking the vessels in the lungs. So that's what is the scenario going to be like. The scenario: IV drug user having cough and a little bit of blood tinged sputum, and then they're going to give you an CT scan, and you're going to see nodules in the lungs. So that is how the presentation usually comes. And so I'll also show you the so septic pulmonary emboli, nodular peripheral opacities, cavitations like these. So the thing is here, you don't have to, the thing that you need to keep in mind is you don't have to confuse it with TB or anything else. Like the patient who is an IV drug user can also develop AIDS, so you might think that it's AIDS and it's a AIDS defining illnesses that the patient is suffering from. For example, the PCP pneumonia, pneumocystic cerevisiae pneumonia, that happens in AIDS patients. You might also think that it's that. So just keep that in mind, that you need to be conscious about the fact that you don't confuse it with other AIDS defining lung associated illnesses, because yes, infective endocarditis in an IV drug user can affect the lungs, and I explained how it does. So, septic pulmonary emboli present in 75% of the cases. Murmur may be absent, murmur is not. Few peripheral manifestations because the left side of the heart is clear. Septic pulmonary emboli typically cause cough, chest pain, and hemoptysis. And on chest imaging appear as multiple round nodular opacities with or without cavitation. So these cavities or nodular opacities, especially in a drug user, might make you think of other diagnoses as well, like I just PCP pneumonia. So that is one example I am giving here. So you need to be conscious about that here. HIV greatly increases the risk of IE, most commonly at the tricuspid valve, in patients who use IV drugs. Patients typically present acutely with fever, chills, pleuritic chest pain, dyspnea, and cough. That is the presentation. So the main thing here is you being able to differentiate that it's not an AIDS defining illness, it's an effective endocarditis that is causing the lung trouble. It's not a primary lung disease. Although tricuspid regurg murmur is often present, can be absent. Yeah, you don't have to give that much of fuck about the tricuspid regurg. Diagnosing IE in patients who use IV drugs can be difficult. So that's why I mentioned it here. Can be difficult and requires a high degree of suspicion. Septic pulmonary emboli, usually due to staph aureus, occur in 75% of the patients with tricuspid involvement. This is really high yield, and this happens. The lung involvement does happen. Chest CT typically shows pulmonary septic emboli appearing as multiple nodular peripheral opacities with cavitation. So that is what you need to keep in mind. You need to keep this image in mind, that this is how the septic pulmonary emboli due to infective endocarditis of the heart side appears on a CT. This is how it appears on a CT: cavitations on the periphery and nodules on the periphery, plus this is how it appears, plus the fact that the patient is going to have lung manifestations like pleuritic chest pain, dyspnea, and cough. So this is the takeaway point. Culture positive infective endocarditis. So they're gonna give. So in this table, they've given all the reasons for implicated organisms in different cases of infective. If the person has prosthetic valves, has IV catheters, implantable devices, it's gonna be Staph aureus, because Staph aureus can go from the skin to the prosthetic valves, intravascular catheters, and Staph epi. It is also located in the epidermis, and it is also really notorious for forming a biofilm and adhering to the prosthetic valves and prosthetic joints and everything like that. So prosthetic valves for intravascular catheters, implanted device. So Staph aureus and Staph epi have the same, you know, etiology behind both of them. Both of them, like prosthetic valves, both of them are on the skin and can be contaminated from intravascular catheters. Both of them are implicated in implanted devices like pacemaker, defibrillator. Both of them, these are the stories that both of them are associated with. Staph viridans. It is associated with gingival manipulation. It is a normal bacteria of the mouth, and when there's gingival manipulation or a dental extraction or something like that, the transient bacteremia can result in infective endocarditis with strep viridans, because it populates the mouth. So Streptococcus galactococcus, Gallolyticus. So it's a really it's a really fucked up name. So formerly as bovis. So the most high yield thing about this Streptococcus Gallolyticus is that if you find a person with infective endocarditis, they're going to give you this question, and it's frequently asked that they give you a person that has infective endocarditis. They do a culture of the blood, and it gives strep S. bovis. So they're gonna ask you what is the next best step for this patient. The next best step for this patient is gonna be a colonoscopy or a lower endoscopy. Why? Because basically colonoscopy or a lower endoscopy. Why? Because it is highly associated with colon carcinoma and IBS, inflammatory bowel disease, IBD. So they go hand in hand. So I just explained to you this question because you're gonna face this one as well. They're gonna give you IE patient with culture positive S. bovis and ask you what is the next best step. The next best step is gonna be colonoscopy, because this mahafa is associated with colon carcinoma and IBD. Fungi, immunocomplex. The most likely underlying organism can be inferred based on the preceding procedures as follows. So if a patient had a procedure, they ask you what is the most likely organism causing IE. That is where this table comes to use. They say the patient had a dental extraction, you're going to go for viridans. They say the patient has colon carcinoma, you go for S. bovis. They say the patient has prosthetic valves installed. What might be the organism? You say it can be Epi or Staph aureus. They say the patient has had an intravascular catheter for a long time. You say it can be Staph aureus or Staph epi. They say the patient has a long history of inflammatory bowel disease like UC. Then you're just going to say UC. The patient is a UC patient for 20 years and now has IE. What might be the cause? You say S. bovis. So that's how it goes. Viridans, a group of one more thing. Other organisms and bacteria of streptococci viridans are group. This group includes streptococcus sanguinis. You need to remember these names as well, because they're gonna ask you that the patient has dental extraction, and the option you're gonna have streptococcus mitis, and you'll be like, I only studied viridans, where did this come from? So yeah, you need to keep them in mind as well. Sanguinis, mitis, mutans, milleri, MMM. So you just keep the sanguinis in mind. Viridans, you already know sanguinis, and the rest three are M. Mutans, mitis, milleri. So enterococcus cause IA infection of endocarditis following gastrointestinal or genitourinary procedures involving an infected area of mucosa. Yeah, nah. Staph aureus and Staph epi are most common cause of IE following skin and soft tissue procedures in areas of infection. These skin commensals are also the most common cause of IE in users of IV drug users, obviously because they populate the epidermis. That's how you reach almost all of them. Although mitral valve prolapse, one more thing, you will mitral valve prolapse also, even though the risk is 5 times greater of developing IE if you have MBP, but when it overall risk is really low, particularly compared to the relatively high prevalence of MVP. What do they mean by that? They mean that if 1000 people have mitral valve prolapse, maybe one or two or five of them would develop infective endocarditis. So yeah, it does make you prone, but it does not make you that prone that you need to give a prophylactic antibiotic prior to a procedure that may cause transient bacteremia. So that is the discussion here. In addition, pre-procedural antibiotic prophylaxis has not decreased eye incidence, and many cases of infective endocarditis develop following transient daily episodes of bacteremia. So that is what they want to point it out. that if you're destined to have infective endocarditis, you will have it. And you don't need a procedure that causes transient bacteremia. The daily transient bacteremia is going to be enough to fuck you up. So this is what they mean by that. So you don't need to give a prophylactic antibiotic prior to procedures associated with transient bacteremia like dental extraction, veneer placement, root canal, etc. You don't need pre-procedural antibiotics when it comes to preventing IE, because if you're destined to get fucked, you'll get fucked just by transient daily bacteremia. You don't need that specific procedure.